Dear friends, welcome back to my channel. Oh no, it's our channel. Welcome back to our channel. I hope that you have enjoyed and have benefited by the preliminary topic of function and structure of the eye. Today in this episode on ophthalmology, I am presenting the next topic on the refractive qualities and deficiency of the lens of the eye. You will notice that though these presentations are primarily meant for MBBS teachers, they can be useful and interesting to school students and many others seeking general knowledge. So please subscribe and share the channel or the link to your friends and family. Okay, now let's go to episode of number 2 on ophthalmology. Today's topic of discussion: physiology, optics, and refraction. Let's look into the topic vision and its physiology. Vision. There are different types of eye movement. Fixations are comparably static points where the eye rests. The eye is never completely still, but gaze position will drift. The drifts are corrected by microsaccades, small fixational eye movements. Vergence movements involve both eyes for an image to fall on the same area of both retinas. This single this results in a single focused image. Saccadic movements make jumps from one position to another to, to rapidly scan a particular scene or image. Lastly, pursuit movement, a smooth eye movement that follows objects in motion. The image shows visual pathway, the pathway by which the image or the light coming from the image is converted into signals and taken to the brain, and then from the brain the signals come back to the eye through the optic nerve, and then we see the image through our eye. Lens. It is a transparent biconvex structure suspended in a saucer-shaped depression called patella fossa, which is behind the iris. It helps to focus light on the retina. It provokes a fine-tuning adjustment to the primary focusing structure of the eye, which is the cornea. Its epithelium is a single layer on the front, that is the anterior surface. There is no epithelium on the posterior surface. Thickness and weight are gained with age. That means as the age increases, the thickness and the weight of the lens increases. Today's topic of discussion: physiology, optics, and refraction. Visual perception, the light and the form sense. Light sense denotes the capacity of eye to recognize light. Light minimum is the minimum brightness required to evoke a sensation of light. Rods are more sensitive to low illumination than cones. Ability of the eye to adapt itself to decreasing illumination is called dark adaptation. Vitamin A deficiency, glaucoma, and pigmentary retinal dystrophy cause relay in dark adaptation. Form sense is the ability to discriminate between various shapes of objects. It is the most acute in the fovea where the cones are very densely packed and highly differentiated. Visual perception, sense of contrast and color. Sense of contrast is defined as the ability to perceive minutest changes in luminance between regions which are not separated by defined borders. It is affected by glaucoma, refractory errors, diabetes, diseases of optic nerve, and cataractous changes. Various charts are available to measure it with grades of gray shades. Sense of color is the ability to discriminate between different colors. The cones recognize three basic colors: the red, the green, and the blue. All other colors are formed by mixtures of these basic colors. Next is light. Light is the visible portion of electromagnetic spectrum. Cornea absorbs rays shorter than 295 nanometer. Lens absorb rays shorter than 350 nanometers. Critical angle, the angle of incidence in the denser medium corresponding to which the angle of refraction in the rarer medium is 90 degrees. Strum's conroid. It is shown in the picture on the right side. Strum's conroid refers to the configuration of rays refracted through a toric surface. Optical axis, an imaginary line passing through center of cornea, center of lens that meets the retina on the nasal side of fovea. Visual axis, line joining fixation point, nodal point, and fovea. Fixation axis, the line joining the fixation point and the center of rotation. Angles of the eye. Angle alpha, the angle formed at the nodal point by the optic axis and visual axis. Angle gamma, angle between the optical axis and fixation axis at the center of the rotation of the eyeball. Angle kappa, angle formed by visual axis and the central pupillary line. In the pseudo-exotrophic, in pseudo-exotrophia, a positive angle kappa is formed and a negative angle kappa is formed in pseudo-esotropia. Visual angle is the angle subtended by a object at the nodal point. Errors of refraction. Hypermetropia, optically normal eye, slightly hypermetropic for red rays and myopic for blue and green. Hypermetropia, it's known as long sight. Myopia is known as short sight. Astigmatism is it is a condition in which the incident parallel rays through the two eyes fall on the different points on retina. Anisometropia. In this condition, degree of error in the two eyes are different. Anisoconia. Images around the two eyes are unequal in size or shape. Presbyopia, the want of ability to accommodate, that is, to view objects between a near and a far point. Hypermetropia, refractive error in which the incident parallel rays are brought to a focus posterior to the light-sensitive layer of retina when accommodation is at rest. There are four types. Axial hypermetropia is caused by decreased axial length of the eyeball. Curvatural hypermetropia is caused by the flattening of the curvature of cornea. Index hypermetropia is caused by the increase in the refractive index of the cortex of the crystalline lens. Positional hypermetropia is caused by the backward displacement of the lens. Types: latent is corrected by ciliary tone. Manifest, facultative, corrected by accommodation. Absolute can be corrected by placing a convex lens in front of the eye. Features of hypermetropia. As tone of the ciliary muscle decreases with age, latent hypermetropia tends to become manifest and gradually absolute. Normally, far point of the eye is infinity, but with hypermetropia, it becomes a virtual point behind the eye. Rays coming from a point on the retina will be divergent than normal, so the image gets blurred unless the converging power of the eye is increased. Correction can be by accommodation or by using a convex lens placed before the eye, where accommodation is minimal. Symptoms include blurred vision, eye strain, which is due to accommodative asthenopia, false myopia due to excessive accommodation, convergent squint, and early onset of presbyopia. The image shows fundus in hypermetropia. Signs include small eyeball, smaller cornea, shallow anterior chamber, apparent divergent squint, that is large positive angle alpha. Aphakia. It is a condition in which the lens has been removed. Aphakia is the absence of the lens of the eye due to surgical removal, such as in cataract surgery, a perforating wound or ulcer, or congenital anomaly. It causes loss of accommodation, high degree of hypermetropia, and a deep anterior chamber. Total power of the eye is reduced from plus 60D to plus 44D. Anterior focal point shifts to 23.2 mm in front of the cornea from the normal 15.7 mm. Posterior focal point shifts to 31 mm behind the cornea from 24.44 mm. Myopia. Axial myopia occurs with increase in axial length. Curvature myopia reduces curvature of the cornea. Conjunctional myopia occurs in fetus due to hereditary and maternal health reasons. Developmental myopia. It is the most common type and does not progress after adolescence. The error does not go beyond the range of -6 diopter to -8 diopter. Degenerative or pathological myopia. It results from a rapid growth posterior to the equator of the eyeball and is mostly hereditary. Fundus may show patches of chorioretinal degeneration and dark spots due to intracolloidal hemorrhage. This is an image of the myopic eye. You can see in the figure or image that the light is falling in front of the retina, which is marked as focal point. So we have to use, or it can be corrected by using a concave lens so that the image will fall directly onto the retina to be viewed clearly. It is an image showing the difference of vision in a normal eye and a myopic eye. You can see in the normal eye the object is falling, the light ray coming from the object is falling on the retina, and it can, which that is why we can see it clearly. But in myopia or nearsightedness, the light coming from the image, it falls in front of the retina. That means it does not fall on the retina. So we have to use a concave lens to correct so that the image falls on the retina and it can be viewed properly. Complications of pathological myopia, that is complicated cataract, choroidal hemorrhage, tears and hemorrhage in the retina, vitreous hemorrhage, retinal detachment, and the possibility of microphthalmos, congenital glaucoma, retrolental fibroplasia, Marfan syndrome, Turner syndrome, Ehlers-Danlos syndrome. Myopia. Axial myopia occurs with increase in axial length. Curvature myopia reduces curvature of the cornea. Congenital myopia occurs in fetus due to hereditary and maternal health reasons. Astigmatism based on axis and angles. With the rule astigmatism, in this version, the vertical meridian will be more curved than the horizontal. The two principal meridians will be at right angles to each other. Its correction needs concave cylinder at 180 plus or minus 20 degrees or concave cylinder at 90 plus or minus 20 degrees. Against the rule astigmatism. Here horizontal meridian is more curved than the vertical. Oblique astigmatism, where axes are at right angles to each other but not vertical and horizontal. They can be at 45 degrees by 135 degrees. Bi-oblique astigmatism, where the axes also are at any angle, 30 degrees by 100 degrees. This is an image showing astigmatism with the rule and against the rule. In the with the rule, we can see there is a steeper axis at 90 degrees, 44 by 90 degrees and 43 by 180 degrees. It is more common in younger patients and myopic eyes. Now comes against the rule. The steeper axis is at 180 degrees, that is 44 by 180 degrees and 43 by 90 degrees. It is more common in older patients who are cataract patients. Optical axis, an imaginary line passing through center of cornea, center of lens that meets the retina on the nasal side of fovea. Visual axis, line joining fixation. Astigmatism based on refractive error. Simple astigmatism occurs where the rays of light are focused on the retina in one meridian and either in front or behind the retina in the other meridian. Compound astigmatism. Here light rays are focused in both the principal meridia either in front or behind the retina. Mixed astigmatism is where the rays are focused in front of the retina in one meridian and behind the retina in the other. Such patients have comparatively less visual symptoms as circle of least diffusion is formed on the retina. Where the eyes are myopic, the focus is in front and in the back when hypermetropic. Circle of least diffusion. It is the dioptric midpoint of focal lines. The cross-section of Sturm's conoid appears as a circular patch of light rays with best overall focus. Anisometropia. In this condition, the degree of error is unequal in the two eyes. In simple anisometropia, one eye is emmetropic and the other either hypermetropic or myopic. In compound anisometropia, both the eyes are either hypermetropic or myopic, but the degree of error in one will be different from the other. The mixed variety, one eye is hypermetropic and the other myopic. And comes the fourth, simple astigmatic anisometropia. This will have one eye emmetropic and the other either simple myopic or simple hypermetropic astigmatism. Anisoconia. Anisoconia is an ocular condition where there is significant difference in the perceived size of the image. It can occur as an overall difference between the two eyes or as a difference in a particular meridian. If the ocular image size in both the eyes are equal, the condition is known as isoconia. Optical anisoconia occurs in high anisometropia. Retinal anisoconia is the result of retinal edema or scratches in the macular area. Cortical anisoconia refers to a asymmetrical perception in spite of equal sizes of the image formed on the two retinae. Accommodation, defined as the ability of the eye to shift effortlessly the focus from a far object to a near object and vice versa. Near and far points. Punctum proximum or near point. It is the nearest point at which small objects can be seen clearly. It increases with age. Punctum remotum or far point is the farthest point from where objects can be seen clearly. In an emmetropic eye, it is infinity. In myopia, it lies in front of the eye and is in real. In hypermetropia, it lies behind the eye and is virtual. The range of accommodation is defined as the distance between the near and the far point. Amplitude of accommodation depicts the power needed to focus at near point and far point. It varies with age, reducing gradually from 14 diopter at age of 10 years to 2 diopter at 50. Aphakia. It is a condition in which the lens has been removed. Aphakia is the absence of the lens of the eye due to surgical removal, such as in cataract surgery, a perforating wound or ulcer or congenital anomaly. It causes loss of accommodation, high degree of hypermetropia and a deep anterior chamber. total power of the eye is reduced from plus 60D to plus 44D. Anterior focal point shifts to 23.2. Presbyopia. Presbyopia is a condition of age-related physiological insufficiency of accommodation resulting in failing vision for near. It usually manifests after 40 years of age. Causes: decreases in the elasticity and plasticity of lens, decrease in the tone of ciliary muscle and zonules, rigidity of zonules, hypermetropia, primary open-angle glaucoma, general telepathy causing presenile weakness of ciliary muscle, premature sclerosis of the crystalline lens, excessive close work as with computer service or computer devices. Determination of refractive errors. It is done by shadow test. It is also known as skioscopy or retinoscopy. The red reflex in plane mirror retinoscope placed at a distance of 1 meter indicates the state of refraction as follows. If there is no movement, then it is myopia of 1 diopter. With movement, emmetropia or hypermetropia or myopia less than 1 diopter. Against movement, myopia more than 1 diopter. Autorefractometry is an objective method which provides quick data on refractive error in terms of sphere, cylinder, axis and interpupillar distance. It must be supplemented by subjective refraction. Anisometropia. In this condition, the degree of error is unequal in the two eyes. In simple anisometropia, one eye is emmetropic and the other either hypermetropic or myopic. In compound anisometropia, both the eyes are either hypermetropic or myopic, but the degree of error in one will be different from the other. The mixed variety, one eye is hypermetropic and the other myopic. And comes the fourth, simple astigmatic anisometropia. This will have one eye emmetropic and the other either simple myopic or simple hypermetropic astigmatism. Corrective procedure by use of spectacles. Crown glass of refractive index 1.5223 is most commonly used for making spectacles. Resin lenses are made of allyl diglycol carbonate. They are lightweight, unbreakable and scratch proof. Meniscus lenses are used in spectacles of small to moderate power. Lenticular form of lens are used for high plus and high minus lenses. Aspheric lenses are used for high power and aphakic lenses. Corrective procedures by contact lens. There are two types of contact lens, that is soft oxygen permeable contact lens and rigid glass permeable contact lens. Soft oxygen permeable contact lens are made of hydroxyl ethyl methacrylate, which is hydrophilic, comfortable and well tolerated. But they include problems of proteinaceous deposit and getting cracked. It has limited lifetime, inferior optical quality and chances of corneal infection. Astigmatic correction is limited to 1 diopter. Rigid glass permeable contact lenses are made of copolymer of polymethyl methacrylate and silicon containing vinyl monomer and fluoropolymers. It is permeable to oxygen and capable of correcting astigmatism. However, there are fitting difficulties and tolerance problem in the early stages. Corrective procedure of hypermetropia. Hypermetropia is treated by placing a convex lens in front of the crystalline lens. Phakic refractive lenses or implantable columnar lenses are used. Refractive lenses exchange, where there is natural lens is replaced with an IOL is an alternative. Aphakic glasses have certain disadvantages, which include they produce substantial image magnification, pincushion distortion occurs due to spherical aberration, field of vision is limited, there is a lack in the box phenomenon, roving ring scotoma, chromatic aberration is common. All disadvantages of aphakic glasses are limited by the use of intraocular lens. Useful surgical procedures are hyperopic LASIK, hyperopic PRK, holmium laser, thermoplasty, and conductive keratoplasty. Corrective procedures myopia. Myopia is treated by placing a concave lens before the crystalline lens. Cornea-based surgeries such as photorefractive keratomy, PRK, laser-assisted in situ keratomylosis, LASIK are also done. To qualify for LASIK, the patient must be above 18 years with stable refraction for 6 months, free from ocular pathologies like keratoconus, glaucoma, retinal degeneration, etc. Orthokeratology is a non-surgical reversible method of molding the cornea with overnight wear unique rigid gas permeable contact lens. It can be applied to patients below 18 years of age also. Anisometropia. In this condition, the degree of error is unequal in the two eyes. In simple anisometropia, one eye is emmetropic and the other either hypermetropic or myopic. In compound anisometropia, both the eyes are either hypermetropic or myopic, but the degree of error in one will be different from the other. The mixed variety, one eye is hypermetropic and the other myopic. And comes the fourth, simple astigmatic anisometropia. This will have one eye emmetropic and the corrective surgical procedures for presbyopia. Monovision LASIK, presbyopic bifocal LASIK, that is LASIK PRAM, anterior ciliary sclerotomy ACL with tissue barrier, bifocal or multifocal or accommodating IOL, conductive keratoplasty CK. In the next video, we will be looking on the topic diseases of the eyelid and lacrimal apparatus. If you are new to the channel, please don't forget to hit the like button and the subscribe button and the bell icon for the upcoming videos.